Hi everybody, Dr. Nikita Vizniak, and today I'm going to walk you through the most important thing that you're going to be doing with a patient encounter, and that is a detailed patient history. Now, one of the first things you have to decide is, can I help this patient or do I need to send them somewhere else? In which case you're looking for emergency medicine scenarios rather than your outpatient clinic visits. And of course that's going to be things like fractures, strokes, significant injuries that are not manageable in a standard outpatient clinic. There are many mnemonics that you can use. All of this content, of course, is coming from the orthopedic assessment book designed to compete with David McGee and other books that are out there that has a better layout and better content delivery and ultimately make you a better practitioner. But this information is from that text right here where we're looking at, you can do your OPQRST, which a lot of people know, you can do Lost War, whatever else the mnemonic is, it doesn't matter that much. But there is one that is a little bit better to use for more of a musculoskeletal type practice, and that is this outline of LOC-Q-SMAT that we're going to follow right now. So the very first thing you do in your history, and recognize the importance of it, 70 to 90% of your differential diagnosis comes from the history that you take with a patient. If you ask the right questions and listen for the right answers, you're going to be told what's wrong with the person and the treatments that they actually need and want, that you can work together in making that shared person-centered decision-making process. So LOC-Q-SMAT, you're going to start with a very easy open-ended question. How can I help you today? What do you want to work on today? Something like that. Then you're going to progress into location, and location is the L. And the first thing here for location is if they say back or shoulder and all of that, and we'll get into specific regional exams that you may have already seen or that we'll get into here, but regardless, they are going to say something like, I have some shoulder pain. You need to follow the sign language of injury and ask the person to point to that area of injury. So a prime example, we'll use the shoulder since you can see it fairly well on me. If it was the back, of course, you've got to isolate where it is because that's a big region. But if it was the shoulder, oh, I've got shoulder pain. And they do this, and they're running a line down the front of their shoulder. They're probably telling you, I have a bicipital tendonitis or a subluxating tendon, especially if they say, yeah, every time I do this, it goes click, 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 or I can feel this thing snapping out. They've already told you what the problem is by just identifying and understanding the pathologies in the region and knowing the specifics. But it goes better than that. Oh, my shoulder hurts. And they point to the upper portion right here and they say, yeah, you feel when I move my shoulder around, it kind of grinds and clicks away right there. And they're touching their AC joint. You understand that that's going to be an area of pathology. Oh, just wait. My shoulder hurts. And they go across the top, and especially when I lift my arm up like this, they're already telling you they have most likely a supraspinatus impingement issue or some kind of bursitis. Do not give a diagnosis of bursitis. Always try and find the root cause of the pathology. And then we'll go beyond that. My shoulder hurts, and they try and grip deep inside their shoulder like this. You're following that sign language for location. And what you're looking at is probably going to be glenohumeral osteoarthritis if it's an older patient or prior injuries or dislocations, or maybe even a glenoidolabral tear that often has a delay in diagnosis. Regardless, just by knowing the sign language of injury and asking the person to point to the specific location helps you identify more significantly where the pathology is, and ultimately, just right there, make a better differential diagnosis and ideas for your physical exam to come through. All right, next section is going to be onset. When did this start? Was it rapid onset, like a muscle tear or damage, like I've got in my low back right now because I tried to deadlift 300 pounds 2 days ago? Or was it gradual onset where you might see more of an osteoarthritis or insidious onset? The next thing you want to be aware of, not the biggest question, but still good to be aware of, is the chronology and timing. How does it change throughout the day? Is it worse in the morning, worse in the evening? This could be correlated with ADLs if you wanted to, and a way that you can see what makes it better and worse, but we'll get to that question in just a second. Q stands for quality. Can you describe your pain or discomfort in a word or two? And give the patient the chance to do that. If it's numbness and tingling or shooting electrical pain, you're thinking nerves. If it winds up being sharp local pain with motion, you might be thinking like a ligamentous or muscle injury or even cartilage injury. If it is a dull ache, could be more of a muscle injury as well, but you can kind of work your way around that. The next thing is severity. On a scale from 0 to 10, and it's important the verbiage that you use. You can actually change somebody's pain perception by the verbiage you use. Regardless, I've seen people screw this one up all the time. It's not 1 to 10, 1 being a little bit of pain, and 10 being the worst pain you can imagine. If you use the worst pain you can imagine, that scale is so subjective, it's invalid. You're better off saying 0 being no pain or discomfort, 10 being you are bedridden, in tears, and need to be hospitalized. That's a way better scale for you to use. Now, one of these golden questions that you want to ask, the M, is going to be modifying factors. What makes it feel better? What makes it feel worse? And in fact, I would ask those in the opposite. The first thing I would ask is what makes it feel worse? Oh, it feels worse first thing in the morning when I bend forward to touch my toes. It feels better when I move a little bit and I'm actually in a hot shower. And, when I exercise, it actually feels better. All of these things are going to be golden ideas that directly influence the treatment you're going to give the patient. If it makes it feel worse, I'm probably going to shy away from that process. If it makes it feel better, you are definitely going to spend time with those and try and incorporate them, if you can, into the treatment regime for that person. The next thing is going to be associated symptoms. Okay, do you have any numbness, tingling, or weakness? If you're looking for pain referral patterns from nerve root compression, are you looking at visceral referral patterns? Something like that. You want to just rule those out. The other thing is going to be treatments tried. So the T is prior treatments tried, and that can include other practitioners that they've seen, as well as medications, as well as their own treatments that they've gone through and what's worked and not worked. Often a gold mine of information. Oh yeah, I tried acupuncture and it seemed to work for about a day and then it didn't work anymore. Or I'm scared of needles, something like that, right? Or I saw this chiro and they did this, or I saw this massage therapist and it's great for about a week, but then it always keeps coming back. These are important things to get with the contextual idea of relating this to activities of daily living that are going to support optimal function for the person. The last question that I'm usually asking is finishing off with, what are your goals for today's therapy? Usually it's going to be working through a problem, but sometimes it can be something totally different than you expected, and it's important to let the patient make their own list of goals that you can work together with. We can talk more later about a motivational interview as well, but find ways of commonality to motivate this person for shared decision making and best outcomes that result in evidence-informed best practices. So this walks you through a basic history. There's going to be more detailed family and social histories that you can do, but on a simple level, this gets you a gold mine of information that is going to, again, make 70 to 90% of your differential diagnosis, help direct your physical exam, and ultimately the treatments you're going to give that patient. It is fantastic. Follow this process and you'll be a winner.